I want to start with the sort of pessimistic side of my talk and hopefully engender a sense of optimism as I talk over the next 45 minutes or so. You know, I do what I do because I'm a clinician. I see patients every day with psychiatric problems, and I frequently sit there scratching my head wondering what I'm going to do next. Because of the nature of my practice, I tend to get referred patients who have tried lots of treatments, and pretty much by the time they get to me, we're often sitting there wondering what we're going to do next. And this is really a problem across psychiatry and across most mental health conditions, because although we're putting a lot of fantastic and absolutely deserved and necessary efforts into the early identification of mental health problems, developing mental health services, what we really fundamentally lack is a broad spectrum of effective treatments for most mental health conditions. And depression's a great example of this. We all know how common depression is. We've started a great national conversation about depression in recent years. We are seeing patients much earlier on. But in no way is there any evidence yet that has fundamentally changed one of the basic problems with treating depression, which is that at least a third of the patients we treat don't get better with the various treatments that we have. And once you've tried a couple of medications, you don't really get much further. And disorders like PTSD, anxiety disorders, obsessive compulsive disorders are all really very much in the same bag. And you know, I remember very distinctly when I was a psychiatry trainee and an early consultant early in my career, the degree of optimism that there was around new drug development. We'd had the decade of the brain. There were new drugs sort of coming out of left, right, and centre for mental health conditions. But that's really changed. You know, we've discovered that all those new drugs that came out in the 90s and early 2000s aren't much better than what we had in the 1970s. They're a little bit better tolerated, but they're not much more effective. But more importantly, the generation of a new wave of medications is just not happening. You know, in the last decade, 4 of the 6 largest pharmaceutical companies completely stopped trying to develop drugs for psychiatric conditions. Most of them moved their resources into trying to develop drugs for Alzheimer's disease, and now they're all pulling out of that as well, because it's just too hard, it takes too long, it's too expensive, and it's too likely to fall short of getting effective treatments. And even when we look at basic efficacy, we're left short. This is some data analysed in depression from the Ptsd study. This was a big American study where they gave a couple of thousand patients an antidepressant. If they failed that antidepressant, they got a second line of treatment, a third line of treatment, and a fourth line of treatment. And on the left-hand side, it just shows the remission rate, so how likely you were to get better with your first drug, your second drug, your third, and your fourth. And, you know, it's not great. It's 36% the first time, and it diminishes pretty rapidly. And as a psychiatrist, I never see a patient who hasn't had at least 2 or 3 medications before they come to me. So we're looking at, okay, if I prescribe another drug, less than a 15% chance it's going to work. But if you actually look at the column on the right, this is what really frightens me. This is the likelihood that patient will be well in 2 years' time. And the numbers are really quite abysmal. So we really need fundamentally to change that. And in psychiatry, we have effective forms of therapy and we have medications that work in some circumstances. But this is clearly, with what we have currently, just not good enough. And my career and the career of many of the people I work with is dedicated to saying, well, if these things aren't good enough, what can we add to this therapeutic armamentarium to try to ensure that our patients have better options going into the future? And so our focus is really on what we call novel forms of brain stimulation. And there are lots of these. I'm going to spend most of the time today talking about transcranial magnetic stimulation, but there are about 15 forms of brain stimulation at some form of evaluation currently, in early stage clinical trials, late stage clinical trials, or sort of more conceptually being developed. And some of these are non-invasive, they're very benign from a side effect perspective. Some are variants of electroconvulsive therapy, often for severe depression, and some of these are even at the surgical end of the spectrum. And of the 15 or so things that are currently being developed, they won't all work. There's already been a couple of things starting to fall off as decent trials are done and things are found not to be effective. And that's not a bad thing, because we need to sort out what really works and then put our resources from a clinical perspective into making sure the things that work get to patients as quickly and as effectively as they can. So TMS has really led the vanguard as a new and novel treatment for mental health conditions. So I'm going to spend most of my time talking about that today and talk about it in the context of depression, which is where most of the work has been done to date, and also talk a little bit towards the end about its potential use for post-traumatic stress disorder. Now, TMS is somewhat complex, but actually not all that difficult to grasp. It basically relies on an understanding of Faraday's law, which is the idea that if you turn an electrical current on and off very quickly, it will generate a magnetic field. And so we run an electrical current through a coil that's placed on somebody's head that generates a magnetic field. Magnetic fields pass through us without any resistance. And if you apply a magnetic field to something that conducts electricity, it will induce a current if it's strong enough. So you basically go from electricity to magnetic field and back to electricity, and you get the electricity out into the brain without actually having to apply an electrical current to the brain. And depending on the shape of the coil, you can determine the field, the magnetic field shape. And if we actually put two round coils together, as you can see on the right-hand side of the slide, you get this sort of pointed magnetic field that will penetrate a couple of centimetres into the brain. And if you drive the electrical field initially with enough current, you can actually generate a strong enough current in the brain that will make nerve cells fire. So if I put one of these coils on your motor cortex, it'll make your hand move, which is a bit weird. It sort of, you feel this tapping sensation on your scalp and your hand twitches. But we're not sort of interested in just stimulating the brain once, we're interested in doing it many, many times. Because if we make a big bunch of thousands or probably millions of nerve cells fire multiple times, and during a course of treatment we might provide 60 or 80,000 stimulations, we change the characteristics of those nerve cells. Locally, we make the brain more or less excitable, depending on how we stimulate. But those nerves, particularly when we target the frontal areas of the brain, they project throughout the brain and you get a flow-on effect. You activate distal regions in the brain and you change what we call network connectivity. You change the ability of the frontal area of the brain really to regulate other parts of the brain that are involved in things like emotional regulation. So when we do this in depression, what does it kind of look like from a practical perspective? Well, patients come in, they sit in a chair, this coil's placed on their head. They're there for somewhere between usually half an hour or 45 minutes a day. It's usually extremely well tolerated and quite benign. There are some side effects and some patients find it uncomfortable, but in terms of dropout rates, the dropout rates we see with TMS are in low single figures compared to if I put somebody on a new antidepressant medication, probably 15 or 20% of patients are not going to tolerate that. And they do that over a period of 4 to 6 weeks, usually in a standard course of treatment. And so does that work is obviously the critical question. And the answer clearly in 2019 is that absolutely yes, it does. This is something that's been subjected to research now for over 20 years. We have over 50 randomised controlled trials. We probably have more, or we actually do have more studies supporting the use of rTMS in the treatment of depression than we do for any other biomedical treatment in psychiatry where the studies have not been supported by the pharmaceutical industry. Of the literature supporting TMS, there are 1 or 2 industry-sponsored studies, but the vast majority of the research has been conducted by independent researchers sponsored by government agencies rather than by kind of an industry like would support, say, for example, new antidepressant medications. So there's a very robust literature supporting the acute antidepressant efficacy. There are still some issues we have to deal with about what we know about longer-term changes, but certainly there's really no doubt about what happens when you give a patient a course of treatment, and we'll talk a little bit about that. So where are we now? TMS has now been approved relatively widely. It's been available in the US for a decade or so. There have been clinical programs in Australia for a similar sort of duration, but without a Medicare item number, it's really inhibited the development of outpatient treatment. So we have a situation currently where we're probably spending somewhere between $50 and $100 million a year putting patients with depression into private hospitals so that they can have a course of treatment where they basically spend 45 minutes in a chair and then sit in their hospital bed the rest of the time unnecessarily. So we're desperately looking towards getting a Medicare item number to shift that money in, save a lot of that money, but then to redistribute that savings into providing greater outpatient care for a significantly greater number of patients. And we will, within about 4 weeks, we will have the public documentation available about the Medicare Service Committee review of a Medicare item number for TMS. And so we're all waiting with bated breath. This will come sort of in relevance a little bit later on, but not all TMS is the same. There are various ways that these pulses can be applied to the brain. And we know in depression there's level 1 evidence, so multiple clinical trials supported by positive meta-analyses, that there are at least 3 and probably 4 different ways you can successfully apply TMS. One is actually with a type of stimulation applied on the left that activates brain neurons, increases brain activity. The next one is exactly the opposite. It's applied on the right with a type of stimulation which actually reduces local activity. But they probably both affect prefrontal subcortical connectivity in similar sorts of ways. A third type basically combines those two treatments. And a fourth type, which is not yet in Australia, involves a very different sort of TMS coil that allows us to get stimulation into deeper brain regions. That's supported by a reasonable clinical trial, but not necessarily meta-analyses, so probably not level 1 evidence at this stage. And what happens in terms of overall outcomes? Well, the best study we've got informing this was a study that we published a couple of years ago where we actually took data from 1,100 patients that had been participating in clinical trials that we had done from starting at about 2001 till about 2014. So a large number of patients. The main problem with this analysis was a lot of these clinical trials were done a long time ago, and the doses we were using, the duration of treatment, was actually quite low then compared to what we do now. So presumably, we were probably underestimating in this analysis what we're likely to see in day-to-day practice today. And this is what we saw in this analysis. The blue chunk of the pie graph are patients who met response criteria. And the vast majority of these patients actually got well. So just under half of our patients, very treatment resistant. These patients on average had failed 6 to 7 medications. They'd been unwell for many years. About half of those patients were getting well. Another 20% or so were getting benefit without having a complete resolution of their symptoms. And in about a third of patients weren't really getting a response to treatment. And what happens when they get well, the patients go away and they come back and they bring you cakes that look like TMS coils. This was not made by myself and my wife. It actually was generally made by a patient. And I can actually guarantee you I have more than one photo of cakes that look like TMS coils made by some of our patients. As I mentioned before, TMS is not a unitary thing, and it relies on the principle of thinking about disorders like depression or PTSD or schizophrenia, not as disorders of neurochemistry, because for years we've talked about depression as being not enough serotonin. Now we just know that was blatantly wrong. It was a nice, simple inference from what certain medications did, but it just wasn't true. We know that disorders like, most if not all of the disorders that we see in psychiatry are disorders of complex brain networks. They involve multiple areas of the brain. And this is just a brief kind of expression of areas of the brain that are abnormally active in patients with depression. So if we understand what these networks are, which we increasingly do, and we particularly understand where the critical nodes are in these networks, which we are increasingly developing that understanding, we can then think about how we can potentially just target one area and get flow and effects around that circuitry. So in depression, it might look like stimulating prefrontal regions to try to access the subgenual anterior cingulate that seems like a really critical node. In PTSD, a lot of the thinking is around how you use prefrontal or orbitofrontal stimulation to try to change connectivity between prefrontal regions and the amygdala. But it's about trying to think a little bit more in a more sophisticated way about how we affect global brain activity by only stimulating relatively local areas. And the great example of this is actually in a disorder that 10 years ago I never thought we would be doing clinical trials in with TMS, because it's clearly a distributed brain disorder, and that's Alzheimer's disease. If somebody had said to me 10 years ago that TMS could look like a potential treatment for Alzheimer's disease, I would have laughed, because the pathology is distributed and the effects of TMS are seemingly local. But we know now, we're doing clinical trials in Alzheimer's disease, and we see concrete improvements in patients' cognition that translates into functional outcomes. Patients being able to find their way to the toilet in the middle of the night where they couldn't do that before. And that's because of this distributed effect, most likely, rather than local activity. I want to spend a few minutes just talking about some of the things that we're doing to improve the application of TMS, because these are directly relevant not just to what we're doing in depression, but how we need to think about how we apply this technology into other disorders like PTSD, which I'll come to a little bit later on. And the first and most critical of these areas is about targeting. You know, when TMS was first dreamed up in depression, people kind of looked at MRI scans and said, oh, that kind of looks like a good idea to stimulate there. And it's relatively easy to work out where the motor cortex is on anybody. Because as I said before, if you put the coil on the motor cortex, you get a muscle twitch. So what people had literally done is they'd looked at brain scans and said, well, the frontal area of the brain looks about 5 centimetres from the motor cortex. We'll literally just find that motor cortex and measure 5 centimetres, and that's where we'll stimulate. And if that sounds like it's a really rough kind of approximation of where you'd want to do a modern neuroscientifically based treatment, you're absolutely right, it is. You know, if somebody's got a big head, that's going to result in a localization that's very different than if somebody's got a small head. So we need to be able to do much better than those sorts of methods. But when we first started to face this in the area of depression, the question was, well, if we can get more accurately to the site, what is the site? Where should we actually target? So we started off by doing a couple of fMRI studies where we would actually do multiple tasks and look in patients not just where there was a deficit, but where there was a consistent deficit across more than one task. We then did the first meta-analysis of brain imaging studies, again trying to find areas of commonality. And what shone through in this particular analysis was this region here, which was found in a meta-analysis of studies that looked at change with successful treatment. This seemed to be a particular region that we should be thinking about targeting. So we went ahead and did a study. We did a randomised controlled trial where we localised patients based upon their MRI imaging. You can have these sort of sophisticated ways now where you can take someone's MRI scan and you can map that to the surface of their scalp, and you can work out exactly with 1 millimetre level of accuracy exactly where you're putting your TMS coil. And when we compared localisation at the particular site that we identified to the standard methods, we got significantly greater clinical responses, which is a validation that we need to be thinking in a more advanced way than this. Michael Fox's group at Harvard a few years later came up with a really interesting notion, which was that if you, instead of taking brain structure, if you look at brain function, maybe we can get even better localization of where we should target treatment. And so what they did was they looked at the subgenual anterior cingulate, a region marked in this scan with the red dot, which seems to be a really critical node that always seems to change if you successfully get someone better when they're depressed. It doesn't seem to matter if you get them better with a medication or with CBT or with ECT. This area of the brain always seems to deactivate. So what they did was they did resting state functional imaging scans. So patients would lay in an MRI scanner at rest. They would then take those resting state scans, they would put a seed in this particular site, and then the analysis looks at the areas of the brain that are functionally connected by looking at what areas of the brain are oscillating in synchrony with this particular area. And what they found was that there was pretty much always an area in the dorsolateral prefrontal cortex that wasn't correlated with activity in the subgenual anterior cingulate, but was inversely correlated. So when the subgenual anterior cingulate was active, the prefrontal cortex was deactive, and vice versa. And when they looked at the exact location of that particular site, and they went and looked at where people were doing TMS treatment, what they found was that the closer you were to the particular site identified on the imaging, the more likely you were to get better with treatment. And when they looked at our particular target in this down here in D, when they looked at our particular target, that was the closest, that consistently generated a localization that was closest to this site, which was probably why we were getting the best clinical responses. So that's really, really encouraging. And in the last couple of years, we've gone back to this idea, and we've actually tried doing it with group level data. So we get large numbers of healthy controls, we brain scan them, we've come up with an average localization, and we look at how that relates to clinical response. We do it with patients, brain scans as well. But more importantly, we're trying to see if we can do it at an individual level. The problem with all functional imaging data, people make great claims about fMRI and all the wonderful things it's going to do for diagnosis. But in reality, at a single subject level, usually fMRI is completely useless. The signal-to-noise ratio is so low that you look at these scans and you really don't see any meaningful activity unless it's something, really, really a basic brain function like a simple motor movement. But when we actually looked at individual maps of this resting state imaging, found the ideal site of localization and mapped that to where we were providing treatment, we found statistically significantly clear relationship. The closer you were to this site, the better more likely you were to improve. And these maps had a considerable degree of predictive reliability in predicting who was going to get better or not with treatment, with accuracy levels greater than 90%, which in our area is pretty much unheard of in psychiatry. So this needs to be prospectively validated, and we need to think about ways we can actually translate it clinically, but it certainly is a really strong indication that personalisation with imaging can improve clinical outcomes. Our next step is to say, well, can we also improve improve outcomes by personalisation in other domains? TMS is a frequency-related stimulation. We apply pulses at a particular frequency. And one thing that's been almost completely ignored, except for a really sort of, a small area of psychiatrists, a group that would kind of come to psychiatric conferences and have, the last session on the last day that no one would go to, is the idea of the relevance of frequency. Frequency is the language of the brain. Areas of the brain communicate by oscillating at different frequencies in unison. And we're increasingly understanding what frequencies relate to what specific elements of cognitive function. For example, if I give you a word list to remember, you have to remember 7 or 8 words. Your capacity to remember those words will be directly and strongly dependent on the induction of 2 particular oscillations in certain circuits in your brain, the gamma frequency and the theta frequency. Theta's a quite slow wave, gamma's a quite rapid wave, and the number of rapid gamma waves you have within one theta cycle will directly relate to the number of words you can remember. If you have 6 cycles, you'll remember 6 words. If you have 7 cycles, you'll remember 7 words. This theta and gamma relationship seems to be really important. And there just happens to be a type of TMS. All TMS is done at particular frequencies. That is probably important. We don't really fully appreciate why. But there is one particular type of TMS that's actually done at theta and gamma frequency. It's a thing called theta burst frequency, where we provide very short bursts at gamma frequency and we repeat them at theta frequency. And we pretty much universally do that at 50 hertz and 5 hertz. So we provide these short bursts of 50 hertz pulses and we repeat them at 5 hertz. And it's by far and away the most efficient way with TMS to change brain activity. If we do a theta burst protocol, we can get the same effects. With normal TMS that might take us 45 minutes, we'll get the same effects on the brain in 3 minutes. It's a very efficient way of inducing function. So in this particular study, we went back to a basic question to say, can we personalise this? If we got individual subjects, these were just healthy controls. We got them to come into the lab, we did an EEG while they were doing a working memory task. We measured their individual theta and gamma frequencies with a method called theta gamma coupling. And then we compared. What if we just did normal theta burst stimulation where everybody got stimulation with 5 or 50 hertz, or a second type that some people were using which was 6 and 30 hertz. Or we actually stimulated their brain at their own frequency. So somebody might have got 6 and 42 hertz, or 5.1 and 57 hertz. And I won't go into the analysis because it's really quite complex. We were using a measurement of local cortical activation using some method of combining TMS and EEG. But we clearly showed, or Sung Wook, who was the PhD student who did this work, clearly showed that by personalising that frequency, we got greater effects on brain activation. So the next step of this is to take this into clinical trials and try to prove that if we do this in a much broader group of patients, do we get the same sorts of significant advances with treatment? And so whereas I started a few minutes ago saying we were getting sort of 50% response rates, that's with sort of 1995 sort of what I'll call relatively dumb TMS. We expect that adding in some of these improvements, we can really start to look at improving those response rates quite substantially. And we're also trying to change the utility of some of these treatments. So currently TMS is 5 days a week, 45 minutes sitting in the chair for 4 to 6 weeks. It's a long drawn out process. And patients don't start to improve until they're at least a couple of weeks into that course of treatment. But what if we could do that much more quickly? So this slide summarises as a study we published last year, but this was the result of quite a number of years of research, of pilot studies and innovation, trying to come up with a different schedule. And what we did in this study was patients actually just had 3 days of treatment in the first week, 2 days of treatment in a second week, and 1 day in the third. So 6 days in total compared to 20 days. And we found identical clinical outcomes. The differences that appear at the end here are not statistically significant. The patients who had 6 days of treatment did just as well, and their benefits were persisted for just as long as if patients had 20 days of treatment, which is a really significant potential innovation. I'm going to diverge a little bit before I come back to talk a bit about PTSD to give you a very brief introduction to what are some other ways that we can go about changing brain activity outside TMS. I'm just going to really mention one area, which is the use of what we call transcranial electrical stimulation. There are various forms of this, and I've mentioned 3 on this slide. Transcranial direct current stimulation, transcranial alternating current stimulation, and transcranial random noise stimulation. But these are all variants of an idea of applying a very weak electrical current to the brain. These currents are very weak. We're talking about 1 to 2 milliamps. You can run these sorts of currents off very small batteries. Most people feel a tingling on their head, but not much else when you do this. This is, you know, a magnitude below anything else we do in terms of ECT or even TMS. These currents don't induce firing of the brain. They're not depolarizing. They don't make the nerve cells fire. But what they do is only a little bit of the current gets in. Most of it just goes across the scalp because the scalp conducts most of the electricity. But you only need a tiny, tiny bit of current to actually get into the brain to make a difference. And what it does is it doesn't make the nerve cells fire, but it changes the ionic concentration around neurons. And depending on whether if you're using just a straight direct current, under the positive electrode, you just get a very slight shift in the likelihood that nerve cells will fire in the future, and the opposite under the negative electrode. So by itself, this doesn't do a great deal. It's a very subtle, mild form of stimulation. But if it's combined with something that activates that area of the brain, then what you're doing is with the same degree of activation, patient doing a particular task, if it's done at the same time as stimulation, a bigger area of the brain is going to be recruited. More nerve cells are going to fire. And what that results in is in neuroplastic changes that follow on afterwards. And you get changes in synaptic strength that come secondary to the fact that those nerve cells are just more or less likely to fire. There has been, I won't talk about it in detail, but there's been an enormous amount of research into transcranial direct current stimulation. I won't talk about some of that in the context of depression. I might, if we've got time, talk a little bit of it in the context of PTSD towards the end. The graph of publications in this area is like a sort of logarithmic curve heading skyward, basically because the technology is so simple. It's cheap, it's easy to use, so so many labs and groups around the world are doing studies with TDCS. We are no longer actually doing studies with TDCS both at a clinical or an experimental level because we've come to the conclusion that as a technology it's interesting, it has effects on the brain, but those effects are relatively limited. In our clinical studies, the antidepressant effects, for example, are very subtle. They're better if we combine them. We've done studies showing that if we combine them with cognitive control training to activate prefrontal areas, we get better antidepressant effects. But we think that overall, say compared to what we see with TMS, we just don't get the same degree of clinical effect. And there's not a lot you can do with direct current stimulation to enhance the treatment. This is literally somebody here having TDCS with the yellow electrodes. You can get better electrodes, you can make it a little bit more focal, but you can't vary the dose in any meaningful way. There's not a lot more you can do. We see much more promise in a technique called transcranial alternating current stimulation, which is much less proven to date, but we think has a much greater capacity to be used to develop really innovative ways of changing brain activation. What TACS does is it pretty much does the same as TDCS. It causes slight changes in the likelihood of neuronal firing, but it does it in an alternating manner because the current basically goes backward and forward. And what you see here is once the field is, this is just from a neuronal slice being exposed to an alternating current. And what you see is once that current's applied, the neuronal firing starts to line up within the field itself. You induce a synchronous oscillation, and this is called entrainment. You can entrain brain activity. So if your intrinsic alpha rhythm is is 10.3. And we pretty much all have an intrinsic alpha rhythm. It's the one EEG rhythm that is very reliable. You tend to slow down a bit as you age, but if I repeatedly test you at different points in your life, you'll usually have an alpha rhythm that's about the same. So if I apply TACS slightly off your alpha rhythm, I will temporarily shift your alpha rhythm down or up depending on how I apply stimulation. This is this principle of entrainment. And the closer I start to your rhythm, the more likely I'll entrain it, and then I can adjust my exogenous stimulation to drag your rhythm up or down, or to increase the power or decrease the power of oscillations in the way that it's being experienced in your brain. And so we think this has got much more capacity to be potentially used therapeutically for brain conditions because, as I said before, frequencies really matter in brain activation. And we're increasingly understanding what those relevant frequencies are for specific disorders. So we're currently doing studies with this where now, instead of patients having to come in and sit in the office or in a lab or in a clinic having treatment, they can actually do this at home. And we personalise it. So in, for example, the study we're doing in youth depression, our patients come in, they have an EEG in our lab, we work out what their individual frequency is, then we program this little device that I've shown you. We've had about 50 of these made, constructed by a local electronics company so that we can have them programmed so the patient can't change anything. They can turn it on, and that's really it. And if they've turned it on today, they can't turn it on again until it's ready for their next treatment. It's got a battery in there that basically holds enough charge for a course of treatment. They can't plug it into anything except for the electrodes that they're using. So it's kind of really locked down and controlled so that they can't use it in any sort of deleterious way. And it's programmed at their individual brain frequency. So it will only work at that frequency. If they have a course of treatment, then we'll reassess. And we think this sort of technology starts to open the door for us not to necessarily treat thousands of patients, but to treat tens or hundreds of thousands of patients. Because that's the biggest problem with TMS. No matter how good TMS goes and how widely we use it, there is still going to be an access issue that we're not going to get to everybody. And so we're particularly focusing our TACS research on groups that are going to really struggle to get into clinics for standard sort of clinic-based care. Very young and the very old are just patients, in whom getting to clinics on a daily basis is far more problematic. So there's lots of work going on. There are areas with TMS in particular now where beyond depression where we now believe TMS is an effective treatment. We know, for example, that we can effectively treat patients with persistent voices who have a diagnosis of schizophrenia. I should probably shift the OCD bar in this graph to the right as well. A certain type of TMS for OCD has now been clinically approved in the US as well, and that will gradually come to Australia. So there's research across a fairly broad spectrum, but there are increasingly kind of wins within these areas. So what about in PTSD? And clearly, along with depression, PTSD is the other most common post-traumatic mental health problem that we face. There has been lots of different approaches, unfortunately in a pretty patchy way. And this was really what happened with depression and TMS back in the late 90s and early 2000s as well. There have been approaches to kind of really just do what we do in depression. There have been approaches to kind of do opposite things. And increasingly, we're trying to be a little bit more sophisticated and think about the circuitry, think about where in that circuitry we need to target, and try and develop approaches that are much more sort of individualized. But we're not really there yet. And to understand some of this, it comes back to the principle I described before, which is that we have a capacity to increase the brain, increase brain activity with high frequency stimulation, or to decrease it with low frequency stimulation. But those effects are local and they may not translate to what really happens with distal brain areas. It may actually not matter that much what the frequency of stimulation it is. It might just mean that we drive the circuit repeatedly enough times to induce the sorts of changes that we'd like to produce. So, as I said, there have been a number of studies. This was the first one of any sort of size. There's a real problem with sample sizes in pretty much all of this research. This took an approach that looks much like what we do in depression. So activating stimulation on the left and deactivating stimulation on the right. And they studied patients who had a mixture of who all had PTSD symptoms, but they had a significant degree of depressive comorbidity as well. The graphs across the top show improvements on the PTSD checklist that they used as their outcome measure for PTSD. The data below that is data on the Hamilton Depression Rating Scale. They saw clinical improvements. Sorry, I make it clear that this wasn't a treatment combining these two, it was comparing the two, and a third arm was a sham. So they looked at both left and right and a sham treatment. They saw benefits with both left and right-sided treatments, but there was a divergence, so that the PTSD symptoms seemed to improve both with the left and right-sided stimulation, somewhat greater with right-sided stimulation than left, but the opposite was seen with the depressive symptoms, where the left-sided stimulation produced greater effects. So this does suggest that maybe a combination of bilateral treatment approach may give us the best of both worlds, and we'll come back to that a little bit later on. This was a second sham-controlled study just using the right-sided stimulation, so low-frequency stimulation on the right, very low dose, low intensity of stimulation, and only 10 treatment sessions. So really, you know, what I'd regard as kind of only a preliminary proof of concept, but they showed significant improvements in active versus sham treatment on the CAPS, on the PCL, as well as on the Beck Depression Inventory. And interestingly, in this study, the significance of the improvements in the PTSD symptoms was significantly greater than that shown in the changes on the BDI, which probably reflected that these patients only had moderate levels of depression. This wasn't a group of patients where we could really explain their improvements in PTSD by having a dramatic improvement in depressive symptoms. And I think that's important because depression can be a confound. You know, if you look at you rate PTSD symptoms, even on something as simple as looking at DSM-4 criteria, there are a lot of things that overlap between depressive criteria. So we need to be really clear when we're trying to interpret some of this study data. This was a similar approach, so low frequency stimulation targeting the right prefrontal cortex. This time they'd gone from 10 days of treatment to 15 days of treatment, but the actual dose is still a pretty low dose. It was only 20 minutes of stimulation, and they'd increased from the intensity of stimulation is based against this measure called the resting motor threshold, which is basically just stimulating the motor cortex and turning the machine up until you get a muscle twitch. And you would have seen in this previous study, it was stimulated at 90% of that measure. So if my motor threshold's 50, they would have used 45, because that's roughly 90% of my motor threshold. In this study, it's gone the wrong way. In this study, we've gone up to 100% of the motor threshold. To give you a comparison, in depression, the very first study that we did back in 2001, we used the same sort of dose of about 100% of the motor threshold. The standard clinical dose we use now is 120%, which doesn't sound like that much difference, but is actually a very significant difference in terms, you know, it's a 20% increase and results in a fairly substantially greater area of the brain being activated. But you know, for what we have, that's what they did in this particular study, and you can see here both CAPS total scores and the re-experiencing scores on the CAPS. And I think the most important lesson from this data is if you look at, you know, after the 4-week time point, there was very little or absolutely no difference between the groups, and they start to diverge by the end of the study. And this is the same if we look at almost all depression studies as well, that you don't tend to see plateauing of response in most of our studies. So if we'd gone, you know, if they'd gone another 2 weeks, another 4 weeks, what would have that mean? And consistently in depression, we know the longer you go on, the better you patients get. And we don't really know when the end of that is. So this is certainly, again, it's an encouraging finding. There's only a relatively small divergence from sham here, but what we're seeing is an increase in this over time. And that's certainly consistent with what we see with other effects. Of all of the studies that have been done in PTSD, I actually think this is the one that's most important. Not because of the TMS elements, but what it reflected in the way this study was designed and constructed and what this means for what we should be doing going forward. So this was a study sponsored by a company called Brainsway. Brainsway is an Israel-based company that makes a particular type of TMS machine. They were the second company to market in the US. The first company to market was a company called Brainsway. They got approval back over 10 years ago. They had a monopoly on the market for 5 or 6 years. They didn't do a single additional clinical trial after they went to market. They just tried to make money. Brainsway, for all their flaws, and there are flaws, I won't talk about them in public, but you're welcome to ask me about them. They've got some significant problems with the way they've done certain things. The one thing they've had is they've had a really substantial commitment to innovative research. And they've done clinical trials in a whole range of novel areas, including in PTSD. Their system has a very unusual TMS coil. It's like, it sits in almost like a bucket that sits on your head, and it produces a deeper penetrating magnetic field. That deeper penetration may not really matter. It's actually more uncomfortable, and it's more likely to induce a seizure, which is the one kind of risk with TMS. But it does give us, in an area like PTSD, the capacity to target some interesting other brain regions that we otherwise might not think about. And in this particular study, they were claiming that they were stimulating the insula, particularly because they wanted to try to down-regulate insula amygdala hyperconnectivity. That was kind of the theory behind what they were doing. But that actually is not the interesting thing about this study. The most interesting thing about this study was before they gave people treatment, they actually went through a scripted exposure protocol. So there were 3 arms in the study. You either got exposure and then you got a placebo form of TMS. You had a sham exposure, which was just a script without it really being developed to induce traumatic memories, followed by real stimulation, or you had the traumatic exposure followed by active stimulation. And and it's hard to tell because of the lack of colours on this graph, but the line at the bottom across all of the graph is the combined group. That if you did traumatic exposure and then you had active stimulation, you got statistically significantly greater anti-PTSD symptom effects and antidepressant effects as well. So this is consistent across both their PTSD and their depressive symptoms. And I think this is really critical. It's opened the door for people to start to think much more rationally about, okay, well, if we are trying to downregulate a particular circuit that's involved in, say, a response to traumatic memories, it makes more sense to activate that circuit, have the person have that experience and downregulate that. This company has now gone on to, in a very similar way, to prove that if you use an exposure paradigm in obsessive compulsive disorder and you downregulate brain activity with TMS, you get successful anti-obsessional effects, and have now got their device with that exposure protocol approved for clinical use in the US, which is a really important validation of this model. And it means that, we as brain stimulation scientists can't just think about neurons and electricity and so forth. We have to think about what is the experience of patients and how do we combine that into the sort of methodology of the protocols that we're developing. As I mentioned before, there is this question about whether the frequency matters. In this particular study, they just treated the right side. As we've kind of gone along, there's been an increasing emphasis on protocols looking at the right prefrontal cortex, particularly given its very known strong connections to the amygdala and some other areas of PTSD circuitry. And in this study, they directly compared high and low frequency stimulation, which at a local level have different effects, as I said before, maybe not so much at a distributed level. What they found here, if you look at the core PTSD and depressive symptoms, that they improve with both treatments. But there seemed to be some improvement, greater degree of improvement in function with the high frequency stimulation. When you look at depressive symptoms, there was again no difference between the groups. So both types of stimulation seem to produce antidepressant and anti-PTSD effects, with maybe some suggestion that those improvements are greater or translate functionally to a greater degree when you use the high frequency stimulation. The same group did another very innovative study which they published at about the same time last year. What they did was they got a group of patients, and instead of doing a kind of standard course of TMS on a daily basis over 3, 4, 5, 6 weeks, they actually just did a weekly stimulation session, but they did it immediately before they had a session of cognitive processing therapy. So this was really a question around not does TMS improve your PTSD, but Can TMS improve the likelihood that you'll get benefit from a psychological type of therapy? Did this in an active way or a sham way? So everybody got the cognitive processing therapy, but some people got active stimulation before, some got sham stimulation before. They had 12 or 15 sessions on a weekly basis. If you'd asked a TMS researcher just doing a single TMS session once a week, would you expect to see anything clinically? We would all kind of say, no, you wouldn't. It's a very, I think, very specific effect to the combination of the stimulation with the cognitive processing therapy, and is what you can see here is, again, a quite clear difference that emerges by a month and then persists over time throughout the duration of therapy, both in terms of PCL symptoms and on the CAP. So again, a very strong suggestion that if we're going to be doing this, we need to be thinking innovatively about how we combine treatment with other forms of particularly cognitive intervention. There's now been a relatively small meta-analysis just trying to summarise the studies using TMS in PTSD. In this analysis, they identified 18 studies. There were 11 that they could include. And they found that TMS overall, in the meta-analysis, did have a statistically significantly greater effect than sham at improving core PTSD symptoms. Low-frequency forms of stimulation seem to improve both core PTSD symptoms and depression, and high-frequency symptoms clearly had a greater effect on PTSD. This analysis didn't include that later study of high-frequency versus low-frequency right-sided stimulation that I presented before. So it's a little bit out of date already, and that study may change the conclusion of low-frequency being better, because that study actually found a slightly divergent response. But anyway, it's certainly promising. I want to briefly mention one or two studies that have been done with the non-invasive forms of electrical stimulation, particularly with TDCS. There is some TACS work, the alternating current stimulation, going on at the moment, but none of those studies have yet been published. This particular study was interesting, and I present it really because, again, it reinforces what I was talking about before in terms of combining therapies. So they provided stimulation between two electrodes. One on the graph is marked red. That's the positive electrode. The negative electrode's here. They were driving the current really through left orbitofrontal regions of the brain. And they combined this with exposure in a virtual reality environment. So you had stimulation during a VR-based exposure. Now, whether or not you should do stimulation concurrently with exposure, or you should do it beforehand or after, that's a completely unanswered question, and they're the sorts of things we're going to have to tease out in future research. This was a tiny pilot study, but they showed the emergence of greatest therapeutic responses with exposure with active stimulation than with sham stimulation. So I want to present just a little bit of local data. The first data is from a study that we've done, an initial pilot study we've done with Phoenix, Australia. This was to test a quite novel form of TMS. It's the type of thing I mentioned to you earlier on, the thing called theta burst stimulation, where we get very rapid antidepressant or very rapid changes in brain activity with stimulation in a 3-minute protocol. And we applied this bilaterally. We thought, based upon the studies that are showing improvements with both left and right-sided treatment, we can do theta burst stimulation so quickly that it's quite practical to do this bilaterally within treatment sessions. And we did this in a small group of patients with PTSD, and we've showed some modest improvements in both CAPS and HAM-D scores over time. There are a variety of things we think we can do to substantially improve on this, and in terms of improving outcomes in the future. One is what we talked about with the imaging earlier on. Secondly, there's the possibility of individualization of frequency, but more importantly, we can substantially increase the dose. These patients only had really 6 minutes of treatment, 3 on one side and 3 on the other. So we can build a treatment protocol that actually allows them to get a substantially higher dose than that, and then test out how that works. I'll also just want to show you a little bit of data collected through TMS Australia. TMS Australia is a network of private psychiatric clinics that provide TMS treatment, predominantly to patients with depression, but over the last year and a half or so, we've had quite a number of patients come along, predominantly with comorbid PTSD and depression. And so we decided to have a bit of a look at the data from those patients to get an idea of what sort of outcomes we're getting. Are we only getting improvements in their depression, or do we see something in terms of their PTSD symptoms as well? These were a group of patients, middle-aged, who have basically been unwell for quite a long time, and mean illness duration of 8.6 years. And a lot of patients, that's a single episode of 8 years duration. It's not, you know, they had one episode 8 years ago and they've had another episode for the last 3 weeks, and they've failed on average 7 medications prior to the time of coming to TMS. We used a protocol of high-frequency stimulation on the right and low-frequency stimulation on the left. It's kind of very similar to what we do in one of our depression protocols. And we did that because we know that works in depression. And as I said before, these patients were coming with depressive symptoms. We thought we have to do evidence-based treatment that we feel comfortable providing for their depression treatment, but let's also look at what happens to their PTSD symptoms as well. And so this is just global data. It's not sham controlled. This is clinical real-world data. The green data is improvements on the PCL, and the blue and red lines are improvements on the clinician-rated and the patient-rated quick inventory of depressive symptoms. The red line is the clinician-rated depression, and the blue line is patient-rated. As you see here, highly statistically significant improvements across both PTSD and depressive symptoms of a similar sort of magnitude and a similar sort of degree. The red line here is just general anxiety, and the blue line on this slide is improvements in the WHO-DAS, so a measure of sort of functioning and quality of life. So again, we're really seeing global improvements in depressive symptoms, improvements in core PTSD symptoms, improvements in anxiety, and functional and quality of life improvements, which sometimes you don't see in psychiatry studies. If you look at a lot of psychiatry studies, you'll often get statistically significant improvements in core symptom ratings, and not necessarily does that always translate into measures of quality of life and functioning. So this is promising. It's not sham-controlled data by any means, but it certainly it gives us a very good sense that we're getting symptom improvements across domains, not just in the depressive symptoms, which are our primary target and the primary reason for why we're doing treatment. So in summary, you know, TMS in depression is clearly an effective, safe, very well tolerated treatment, and one that we need to get out to more patients because there really is a pressing clinical need, and we're working very hard both at a funding at a government level and at a clinic level to try to find models that allow patients to get access to treatment. You know, if you have to travel into the Sydney CBD, I actually don't know the suburbs of Sydney very well, but I know Parramatta, is that an outer suburb, somewhere a long way away? You know, you're not going to do that every day for 6 weeks. You've got to have treatment access somewhere close to home. And maybe to get access to, you know, remote and rural areas, we've got to look at home use devices as well, or how we support remotely patients to get access to treatment. In PTSD, it certainly looks promising. We're really where we were at probably 10 years ago with depression, where we've got lots of promise, but what we're really desperately lacking is one substantial multi-site trial, the sort of trial that will allow us to get sort of regulatory approval. I know there's a lot of interest in internationally, where we're certainly talking to some of the groups in the US that work through the veterans associations and about trying to get some multi-site trials up and running. And so hopefully this is something we will deal with over time. And just as a credit, Romy Dwash, this is publicly identified as an artwork that sits in the Cunningham Dax Museum at Melbourne University, which clearly shows a rather stylised version of a TMS call, but actually probably a fairly realistic representation as well. So thank you very much for your time this afternoon. I hope, as I said, I started with a pessimistic note but ended with a degree of optimism. I think we have done a lot and have a great deal we can continue to do, but this requires lots of people and unfortunately a fair bit of money as well. So we've been fairly fortunate that we have a number of foundations and other sources of funding that have supported the research that we do, and hopefully will continue to do so. So thank you again for your time.